And thank you to Linda Anderson. Okay, so we will close agenda item 1. As a reminder, action may not be taken on any matter brought up in public comment until scheduled at a later meeting. So we'll open it to anyone who would like to speak.
I would, Madam Co-Chair, Esther Quillisi.
Good morning, Esther.
Good morning. My remarks go to the urgency that we have in the state of Nevada to make our licensing for behavioral health professionals and possibly SUD professionals quicker, more efficient, and less discouraging. And, you know, this is something that we as an organization or all organizations need to focus on. I mean, I don't know if I'm the only one that seems to be focused on the licensing requirements. If we don't focus and improve those, we discourage so many people. We've had 3 people that said, no, it's not worth it. This lately that they just, you know, we've had somebody waiting on the list as an LCSWs too. I thought sometimes it goes pretty fast and sometimes it doesn't, but we had a CPC application that started the end of January and she just got it. And yet her clearance for Vitality Unlimited went through in a week and a half, and her clearance for the Board of Examiners for Alcohol, Drug, and Gambling Counselors went through in 2 weeks. So we just have, I mean, please, I think we should make this an agenda item, and I think we should all focus on it. And legislatively, I think we have to help manage it better. So that's my concern. And then I do believe that you know, we have other things we can focus on, but I'd like to talk about that every time we meet. How can we all together work and make this a better process? The one suggestion that came up is to belong to a consortium of states that, you know, everyone, Utah just joined this consortium. And they'll allow people to come in that have been licensed in other states. I mean, what's wrong with that? You know, I just don't see why Nevada needs to lead the pack. We don't need to be 50th all the time. Thank you.
Thank you, Esther. And I can that specific issue. And I can chat with you offline after the meeting about that. Any other public comment?
Yeah, this is David. I raised my hand, but I guess it didn't
Sorry, David. Oh, I now see it. Good morning.
Okay. Good morning. Hey, I wanted to echo most of what Esther was saying. We have a major workforce crisis in the state of Nevada, and it is not up to the clinics to try to fix that for us. Nevada should be embarrassed. The government of Nevada should be embarrassed about this, especially ironically, since they put out a NOFA to help with workforce, but it all goes to the universities and has no immediate effect. That will not affect or help Esther in Elko or anybody in the rurals, and it certainly isn't helping anybody in the urban setting. We are going without people. We are competing with online services who are willing to pay a ton of money out there to get people signed up, and it's in my opinion, it's very unethical, much of what they're doing. And yet the state is completely silent about this issue. We put in an application, kind of an out of the box, because they requested one, to support and expand workforce locally, and they said we didn't make enough points in whatever it is. I have no idea what the freaking points were. There were no points. They never acknowledged what the points were, and it was, considering it was out of the box, it's like, what points did you even consider? You didn't give that to us ahead of time, just said present something. So we presented something in good faith. It was thrown out. From what I understand, Richard Whitley is supportive of workforce development and expansion. Nothing has happened. I've yet to see that man even come to Las Vegas and visit with our agency. And we've had a CCBH here since 2017, and we have a second one as well. So I'm waiting for the state to take some action because it hasn't happened yet. And I'm a little tired of it. We're doing our own the best we possibly can. And I will tell you, I'm freaking amazing about providing benefits and getting people to work in a really comfortable place. But that time is over. That time is over. We just do not have the people here and the ones that are willing to actually do the hard work in the nonprofits where we are all working. So anyway, that's my little bit of information or thought for the morning, and I'll be quiet probably the rest of the day since I'm not co-chair anymore. Thank God.
So good for you,
Thank
David.
you, David.
for
I
saying that.
appreciate that.
So I want to say one more tag on remark through David about putting these applications in and being told to CCBHCs that they don't want us to supplant services. When we say, no, it's an enhancement, they say you're a CCBHC. So it's not always rosy to be a CCBHC. And we have lots we do. And when we try to add on, that's what we're told is, well, oh, you may be supplanting that. And so it's tough, David. I agree. And so do we. We pay good high salaries, good benefits. It's so arduous to get people into the state. So, nobody else is saying anything. This is peculiar. Your behavioral health, you mean you have all the workforce you need and you have everything is rosy? No one else but David and how we get it done more effectively and efficiently? Guess not.
I just wanted to add, I know that David and I talked about this. We are, from the SAP certification standpoint, we're very careful of outside organizations, like outside of the state want to do, telehealth services. We are requiring SAP certified within the state and have bricks and mortar. And so we are trying to deal with some of that on that level. And of course, that's only for programs that are required to be SAP certified, which would be provider type 17215, or if they're receiving any state funding for SUD. So we are trying to do some things on that level. I think the Board of Examiners for Alcohol and Drug Gambling Counseling is trying to look at the supervision requirements, who can supervise. So there is some work on that end that would streamline some things as well to get people up and going. So I know some of that's going on. I don't know all the details, but I heard that in the wind somewhere. So, but I totally hear you, David and Esther. It's a struggle right now, workforce. And I did speak at a legislative committee about 2 weeks ago, and I brought up workforce at that committee. So.
Thank you. And Laura, you have your hand up.
Yes, and I want Esther and David and Mark, of course, knows that the coalition's back. Sorry, my microphone was up on the top of my head. That the coalitions fully support the reciprocity being simplified to bring resources into our communities. And we speak at statewide meetings, and we speak to funders, and we speak in our own coalition meetings regarding that. So there is full support of the coalitions in the state of Nevada, with the realization from counselors to psychologists, behavioral health workforce needs. So we are speaking out, we are supporting to the best of our abilities, and unfortunately we are being heard maybe at the same level you guys are.
Thank you. Thanks for your support.
Thank you. And Linda Anderson.
Just quickly, nothing makes me prouder as a former DAG to hear Esther going for the open meeting law and bringing this discussion in. I am now with the Nevada Public Health Foundation, so I want to be clear and put our prior discussion on the record. I appreciate, Jamie, that you had some concern about how the agenda was written for the coalition criteria. I just want to create a record that that was part of our goal in creating that criteria, is to make sure we remove any stigmatizing language and to be culturally competent. So if that's part of what this group is looking at, we would be supportive of that being part of your review if you decide to go forward today after consulting with your real DAGs. Take care.
Thank you, Linda. I appreciate you putting that on the record.
That's
Any other public comment? Wonderful. We will go ahead and close agenda item number 2 and open agenda item number 3, approval of the minutes from the last meeting. I know those just went out yesterday afternoon. Has everyone had a chance to review them?
I do, and I'd like to move for the approval with one correction. I didn't vote nay on you. I didn't vote yay on you. I guess I just did. I was silent, so you better put me as an abstention. But the rest of the minutes look pretty darn good to me.
Thank you, Esther. I'll make that correction.
Wonderful, thank you. I have a motion on the floor with a correction. Do I have a second?
This is David. I'll second it, although I did notice, and I can't find it right at this moment, that I added, there were 2 words used that should have been only 1 word in something I said. So I reserve the right to run back and send you the correction so we can pull the 1 word out. So I don't sound like a blithering idiot. So, but I do give a second. Thanks.
And that way I get it proper.
Wonderful. We have a motion and a second. Is there any discussion? Wonderful. Let's go ahead and put it to a vote. All in favor, please say aye.
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 Opposed? Abstentions? I'll abstain. This is Jamie. I was not here, so I'm abstaining. Wonderful. Motion passes. Thank you so much. We will close agenda item number 3 and open agenda item number 4, which is substance use disorder prevention criteria in response to Senate Bill 69, removing stigmatizing language and striving for cultural competency. Mark, the floor is yours. Mark, you're on mute.
Mark, discipline for the record. I probably did this last time related to the ACT criteria, but I always think it's good to have a little background on why we do division criteria. So I always have a little snippet on that. I made notes so I would not free associate and talk longer than I need to. So division criteria process is under Nevada Administrative Code 458. NAC 45818 describes the process. NAC 458 is unique in that our profession can develop criteria that further describe services within the regulations, as long as these services are nationally recognized for prevention and treatment. The steps are as follows based on DAG interpretation in the past. Presentation to the SAB board for review and approval. 2, if approved, it is submitted to the division administrator for review and approval. Then it is published in the administrative manual of the division and posted on the internet at the dpdh.nv.gov website, and also mailed to each certified alcohol and drug abuse program which operates in the state for prevention or treatment of substance related disorders. So those are things that came straight out of NAC 458-188. In the past, we've utilized division criteria to adopt ASAM criteria, enhance residential treatment services, as well as civil protective custody, which falls under other NRS regulations. Any questions and comments before I get into prevention? Okay, so if you want some heavy reading by the fire with a cup of tea tonight, you can read NAC 458. It's so inspiring. Division criteria for prevention of coalition processes. I just want to give you some background on this. We engage coalitions to give feedback on the criteria and process. Linda Anderson, Michelle Patton, and myself worked together on this along with SAP and the division at the time. we were doing this. NAC 458 allows staff to create division criteria instead of writing formal regulations, which is a long and complicated process. NAC 458.188, which I just talked about. These are the only regulations that have this. Did this, I think Shannon Bennett said that she's used it in her other positions at the state. So there are some other options related to that, being able to adopt other regulations and take them in. We are thankful that LCB allowed this when they did this a long time ago, and they kept it in when we revised the regulations. Division criteria must be approved by the SAB and the administrator of the division before going into effect. We are using SB 69, the statute, as the content for our criteria, as it is detailed enough to utilize for certification. Some statutes don't have a lot of regulatory language in it, and you have to write regulations, but SB 69 very clearly lays out what the requirements are for coalitions. Additional language can be added to the criteria beyond the statute to provide clear definition, operationalization of the criteria. Any additional language must be congruent with statute, though. So you can't write something in division criteria that's not congruent with statute. We have adopted division criteria in the past, and I talked about that. Since the division criteria is developed with specific statutes, this allows for protection under these requirements. We are providing this time for an opportunity to get your feedback prior to, actually we're presenting, and the criteria has been given to you for feedback and open discussion and consideration for passing by the board today. So comments and feedback related to the criteria. Just to note, also Tracy Palmer was involved related to the coalition criteria, and also the coalitions were involved. We actually met with the coalitions, I think 1 or 2 times, to get their feedback. Very, very helpful related to that. And we thank Tracy and the coalitions for that.
Thank you, Mark. I did a review, but I couldn't find my original notes. Were there any from the conversation that you had with the coalitions and Tracy? We went through everything at that point. Was there any changes made after that point?
I don't believe so. If it would be okay for Linda Anderson to chime in, because she was a part of it, she could, she could add to that if she'd like, if that's okay.
Of course.
This is Linda Anderson for the record. I want to again be so grateful to the coalitions because they were really actively involved, caught things that we had messed up, and made some really great suggestions. So I believe we incorporated everything that they had raised to make it a really user-friendly document and to meet those needs. The great thing about criteria, though, is once you start utilizing it, if we discover any issues, we can bring it back to this board and fix those much quicker than if they're in regulations. So we recognize it's a working document to make sure that it is meeting the needs of the community and the folks that are being served by those coalitions.
Thank you. Any other discussion or questions by members of the SEPT Advisory Board?
Jamie, this is Tammy with Churchill for the record.
Hi, Tammy.
Hi, I just have a question because I had pulled up my notes from for the criteria for the final draft, and on where it says the goals of the Prevention Coalition for the immediately preceding year, I have those 2 bullets not there. And I have the trends identified by the Prevention Coalition in preceding years and strategies to address these trends in coming years as added. Am I off there? That's just what I have in my notes.
Linda, Mark?
I have the criteria in front of me as it was provided. Do you know what bullet point that was under?
That is under in consideration with other persons and entities in the state. It's under that bullet. I don't have the exact.
And this is Linda for the record. I just want to note What we did in changing it is reference the statutory language specifically. There was some discussion about how the legislature could have written it a little better or differently. And what we did was keep it with what the statute had said. We can't really change that within this group, but we can, and we tried to make some adaptions within the criteria to make sure that the coalitions are able, for instance, to opt with each other to do a joint report and do some of those things. But I do remember that there were, and I think your point is well raised, as to what's going to be useful in the reports that are going forward to the regional behavioral health boards. And we couldn't change the language that's in statute.
Okay, thank you for that clarification.
Thank you. Any other comments or discussion? All right, hearing none. Is there interest in putting a motion forward? I'm going to gently nudge one of my coalition partners, being as this is coalition language, if one of us would like to make a motion and second it potentially.
Jamie.
Thank you, Wendy.
I didn't know if my mic was.
I have a motion from Wendy Nelson at Frontier Communities Coalition. Do I have a second?
This is Churchill will second it. Tammy will second it.
Thank you, Tammy. I have a motion and a second. Any further discussion? Wonderful. All in favor of approving the substance use disorder prevention criteria in response to Senate Bill 69, please signify by saying aye. Aye.
Aye.
Aye.
Aye.
All opposed? Any abstentions? Wonderful. Motion passes. Thank you so much, Mark. I appreciate it. And thank you to Linda and the team for putting all of that together. That was a wonderful collaborative process, and we as coalitions are always happy to be a part of it. So thank you very much. Closing agenda item number 4 and opening up agenda item number 5, discussion and possible action to adopt recovery housing division criteria to allow the division to provide oversight of services to certify recovery housing service providers seeking funding. Mark, it's up to you again.
Thank you. And I apologize, you're getting too much of me this morning. Okay, so recovery housing criteria, we have had this on the agenda a couple of times, not so much to pass it, but to get like feedback related to the criteria that have been working on with SAPTA, the division. Again, it's the same process that we did for prevention, so I won't go over the steps that I just went over related to why division criteria allows us to do this. Just a little bit of background. Recovery housing is a level of service that does not currently reside in Nevada. We have the closest thing to it is transitional housing, and the division at SAPTA does fund transitional housing. But one of the caveats with transitional housing is that the individual has to meet the criteria for ASAM for level 1 or 2.1 at a minimum. Recovery housing does not have that requirement, and we do have quite a few sober living facilities out there where individuals in recovery need longer term housing, but they don't necessarily need treatment like, level 1 or 2.1. And so the thought behind recovery housing criteria would be to be able to develop that. So if any funding became available down the road, there would be the certification piece and some of the oversight would be laid. Okay, so that's kind of the background. So the National Alliance for Recovery Residents, NAR, approached the division related to establishing a mechanism to certify recovering housing. So NAR is a national organization, their advocacy, they work in a lot of states to try to make sure that recovery houses have some kind of regulation over them. So the quality of the service they provide is, at least at a minimum standard. Through several meetings with the division, CASAT, HCQC, and NAR, we agreed that division criteria should be developed to increase the health and safety of residents, as well as create an opportunity for funding, which I just talked about. Recovering housing is distinguished from transitional housing, and again, as a gap in the continuum of care in Nevada. NAR is giving us, or the state, SAPTA and the division permission to utilize the NAR standards, where the NAR standards differ from current Nevada Administrative Code 458 and Nevada Administrative Code 449 regulations. So 449 is HCQC licensing. We would modify NAR standards to meet Nevada's individual needs. We would take their standards and do much like we do with the DD-CAP for COD, co-occurring disorders treatment, for example, and also with the gambling toolkit we're using for that endorsement. Programs seeking certification would need to be certified under NAC 458 as a recovery house, and also under NAC 449 as a halfway house. So SAPTA certification would focus on the services provided, and HCQC would focus on health and safety. And again, HCQC was involved in the meetings related to this criteria. And of course, the division, SAPTA, CASAT, and HCQC have a lot of common programs, and we work together with that. So that's kind of an overview of this criteria. And again, we have their standards that would become our, standards, that we would modify them to Nevada's individual needs. Any questions or comments?
I do.
Yes.
I took a dive. I went to 449. I took it so that I could get a better idea. First of all, does everyone in a house have to be classed with being in that mode, or can we have people who are in recovery way past that and living in the house?
Yes, that's what the recovery housing would be for. That makes sense.
Okay, so and they don't have to meet the criteria of treatment, because if they've been sober for a number of years, that, really, I mean, they're successful, but they want a sober living environment. So, okay, so that's number one. Got it. Number two, I'm a little confused because we're looking into local regs regarding fire protection. And it says in your regs, well, it's a state fire marshal, and yet here it's the city fire and the city building and the city safety. So tell me it's really confusing.
It is confusing. So we work closely, Michelle Patton and I work closely with HCQC when an application comes in to determine if it actually falls under NAC 449. So for NAC 449 HCQC licensing to apply, it has to meet a definition. And if it doesn't meet a definition, then licensing wouldn't be required. So a lot of times in little cities, we have to take those on a case-by-case basis. For example, some of our transitional houses that the division SAPTA certifies in smaller communities, there's no definition in HCQC, so there's no jurisdiction. But we do SAPTA certify them. So we ask for, something from the local community saying that it is okay for them to have, a house such as this, a transitional house. I would say the same thing would happen with recovery, as long as the local authority gives you, permission, then we can proceed with SAPTA certification. So it does depend, it's much more defined in the urban areas of Nevada versus the rural frontier areas of Nevada. So that's why, either, in the past it was Amir, now Tina Leopard has moved into Amir's position recently. A lot of times, Michelle and I are on a call with Paul Schubert with HCQC, and we just talk through it and figure out the best course of action.
Thank you.
Do what bureaucracy sometimes don't do, and that is be flexible.
Well, that's you. Thank goodness you're there, because you understand a broader picture, and you do have to be flexible, but that's not always what we get. So we have to be very careful about these regs.
Absolutely. Any other comments or questions?
Hearing none, are we ready for a motion?
What's that, to accept it?
Wonderful. I've got a motion on the floor from Esther. Do I have a second?
This is Leo Magardich, and I second it.
Thank you, Leo. Any further discussion? Wonderful. All in favor, please signify by saying aye. Aye.
Aye.
Aye.
All opposed? Abstaining? Wonderful. Motion passes. Thank you so much again, Mark. We appreciate your hard work on this.
Thank
We
you.
will close agenda item number 5 and open agenda item number 6 with the co-chair's report. Jolene, do you want to go first or do you want me to?
You can, Jamie. Thank you.
Of course, wonderful. I just wanted to say thank you so much for to both Lana and David for running an incredibly tight ship the last 4 years. You guys did an absolutely amazing job. And thank you to all of the members for the vote of confidence for both Jolene and I. We're excited to take on this task. As always, if you are interested in making sure that something gets added to the agenda, if you are seeing a standing agenda item that is not meeting your needs, please let Jolene and I know. Let us know what you find value about these meetings, what you don't find value about these meetings. I think it's really important for us to make sure that we are all using our time wisely, and we want to make sure that we are giving you what you need. And we're also giving SAPTA what they need, because we are the SAPTA advisory board. So we are to advise SAPTA. So please reach out to us. If there are thoughts, ideas, something that you desperately know that we need to discuss. I think that that's really important for us to make sure that we use this time wisely. So thank you guys so much. Jolene?
Thank you, Jamie. I commend you. You're doing an outstanding job of running this meeting. You'll be a hard act to follow for me. Good morning, everyone. I was thinking about just the changing landscape of treatment centers, and I'm a licensed alcohol and drug counselor. At Quest, we have about 21 counselors, I think now, both LADACs, but also MFTs and CPCs. And so I think over the course of the pandemic, treatment has changed dramatically. So I just wanted to spend a minute talking about that. I got the opportunity to go to Washington, D.C. For the psychotherapy networker training in late March. I had never been to that training, and I'd never been to D.C., so that was really exciting. Most of the topics that were discussed in that training surrounded health anxiety, which is a fairly new thing that's come about during this pandemic, long-term cognitive, physical, and social effects for many people who got COVID or who had family members who had COVID. There was a great deal on equity, diversity, and inclusivity, as well as discussions on racial tension, social justice, and those issues that wear on clients who then show up in treatment centers. And so in that way, treatment topics have significantly changed over the last couple years. Therapists have to have more skill and knowledge of all of these topics, which I think, means we need to train them to be able to discuss all of these recent events. And then a lot of it dealt with how political issues and wars and social divisiveness is creating different issues for clients who make their way to treatment, which I hadn't really conceptualized myself, but it does pose a lot of challenges for our clients and the clinicians who see them. I think I couldn't agree more with what Esther and David stated about the workforce shortage issues. We've never at my agency really until now had significant issues with hiring and staff turnover, just hiring someone for receptionists. I think we've had like 6 receptionists in a year. That's never been a problem for us. We've had just so much turnover, which is very new. too. I think another challenge for us is that with the inflation rate that's occurring, more people want a higher salary, and they are getting offered higher salaries from for-profit agencies. So as a nonprofit, it's really difficult to contend with that and to be competitive with that. Even if you offer a lot of great benefits for new hires, I think one of the issues that Esther brought up, we have incurred the same challenge. It took 12 weeks for someone to get a CPC licensure in Nevada when it was supposed to take 4. It just kept getting delayed and delayed. And so these are all really, issues that present themselves daily for us in hiring staff and being able to meet the needs of the clients that they're going to see, because then there's delays in people getting into treatment. So I just kind of wanted to talk a little bit about that. And I think one thing I noticed at the training I attended across the country is the burnout factor and burnout rate for clinicians across the country. As a result of the pandemic, the sheer number of people seeking treatments who maybe wouldn't have before, not for just substance abuse issues or, some mental health issues, but people who have never sought counseling before, who are having anxiety and seeking trauma therapy. It's been, I can't even tell you for our agency alone, and I'm sure everyone would echo this, just the sheer number of people seeking treatment that we have to try to accommodate and deal with the complexity of issues that they bring now. And for many of our, like probably eight clinicians that we've hired right before COVID or during the pandemic, none of them know therapy before this pandemic. They only know therapy during the pandemic, which is very different than what people brought to treatment prior to that. So I just, I'm really proud of the treatment centers in Nevada who have met so many of the obstacles. We've not only treatment centers, but all of the prevention coalitions. I think we've had to really learn how to do business differently, long-term, and with a variety of obstacles. So I just wanted to commend everybody for continuing to do all of the good work. And I know it's happening across the state because we refer people out in other places, and then we get their clients back for outpatients. And I just see that we are really meeting the needs of the people that we serve, and that's important. I think that feels really good. So thank you.
Wonderful, thank you. And I want to echo everything Jolene said. I think that, we are on the front line of this, and I think I'm just so proud of all the work that everyone in this room is doing. So thank you, or on this Zoom call, I guess. We are now up to Shannon Bennett giving an update on the Bureau of Public Health, Wellness, and Prevention, if I remember what those letters stand for.
Good morning, everyone. Shannon Bennett for the record. Bureau of Behavioral Health, Wellness, and Prevention. Very close. I know, too many, acronym soup over here. I hope you guys are doing well this morning. Appreciated listening to the conversation this far. So wanted to give you guys a few updates on the Bureau of Behavioral Health, Wellness, and Prevention. I am just over 2 months into this new position. Been taking some deep dives into the Bureau in some of the challenges that you guys may see from the processing and some of our fiscal processes, and really trying to get to the bottom of what's going on and why there's challenges, why we're behind in paying, why we are unable to accomplish some of the duties, the fundamental duties that we're supposed to be able to do to manage some of these programs from a state perspective. And that's taking a lot of time with staff, of just deep dives, digging in, understanding what staff do and do not understand, and how that's supposed to function in a state environment. And that's really what I've been spending a lot of my time doing, is that very detailed work with staff and growing that and fostering the knowledge that they're supposed to have to be able to effectively execute some of this work that's going on. We also have had a tremendous turnover in staff. So I am really working to train staff to a level that I think they should be at, so they are then better able to support the work that you all are doing in the community. So really, we're kind of going through, we're kind of in a transformative stage right now in the Bureau. There's a lot of different things going on. As I mentioned, we have a lot of new staff, and we're continuing to hire for some of those other vacancies that we do have, because we still do have a number of vacancies. What my goal is long term, in about, I think it's going to take about a year, but my goal is to be able to have staff right now consider themselves scope of work analysts, and I tell them that I think diminishes the work that they should be doing. I want them to fully, the program staff to fully come over to view themselves as a coordinator role for a statewide behavioral health program, and be able to speak to it at that level and to be able to support it at that level. That includes understanding their funding, that includes understanding some of the key concept of the program that are going on, and to have staff roles and responsibilities very clearly defined. So that's really what I'm working on. That's really what I'm striving to do. Staff, you know, I'm pushing them in ways that I think they haven't been pushed before, and they get tired of me, I am certain. But I think, you know, the elephant in the room is that we've struggled, and that's what I'm trying to address. And I'm happy to talk with any of you now, or always open to phone calls, and we can have further conversation as well. But that's kind of the update on the Bureau. There's lots of projects going on as well during all of that. And I think Tracy's going to talk about some of that here in a few minutes, and I'll let her run with that. But I'm happy to take questions, you guys.
Okay, I have a question. It sounds hopeful. I just want to know what is the problem with the mechanism? What is it that we submit RFRs September, October, November, December, January, and we have to make an appeal to get part of them paid? And so years ago, we used to submit the request for reimbursement, and within 30 days you paid. I mean, you know, I guess it's a fond memory. So what is wrong with the RFR process? Why do we have to make this appeal to get paid? And, you know, I would like you to maybe tell your staff that when you don't pay an agency for 5 months, it's really dicey. I mean, good thing we had, you know, money that, I don't know, I can't say reserves, but it's a damn good thing we had other sources of income. So I don't know if anybody else has the same problem, but I think it's just getting a little bit better, because we even got a sub-grant award signed, and it wasn't months old, because we were worried about those sub-grant awards, because, you know, that's the continuation of our funding. So at least Denise got us that, and we got it back to her. So rah, rah. So tell me, Shannon, what is wrong with the RFR process? Don't your staff know that we need money?
Yeah, so, and I appreciate that. And I have had that conversation with them. I've told them, like, many of these entities that we're funding are, you know, nonprofit entities. They don't have a bunch of money in the bank that they're able to, you know, meet payroll even, or things like that. So definitely having those internal conversations. I think the system is fundamentally broke in numerous places. One of the biggest challenges that you saw there was we had, like, this is before I started, so this is just what I've been told. There was a mass exodus of staff in December. So, and it was all the other than fiscal staff too, but all the fiscal staff left in December. So I have 4 fiscal staff that have like a cumulative of 6 months of state fiscal experience now, and they're here and they're working through these things, but they came into a mess, if you will, because everybody left and there was not a clear, streamlined process to process these things. So to your point, I appreciate that too. I told them that they will be paying, we as an entity will be paying our RFRs in 30 days. That will be our timeline. That is our goal. That's how it's always worked. Where I've come from in a different place in the division, that is where we will get to. Right now, we're building that process. And as you guys know, all of you guys know, when you're building business processes, it takes time to establish and train. And that is the exact spot where we're at right now. We're doing a twofold approach. We're putting a Band-Aid approach in place right now. And then to get you guys all caught up, that one we are training staff on in a couple weeks. And then later, probably in the fall, we will be doing a brand new process, and that will affect all of you guys as well, because it will be a new flow. And it's going to be a very standardized flow, a very benchmarks that we'll be able to meet and watch our indicators so we can make sure that we're paying timely.
That's amazing. You get that done. You are a Wonder Woman. The other thing I want to bring to your attention is the Detox Certs. So don't come and beat us up, Mark, because we've tried and tried to get these people detox certified. So Shannon, and you know, we need detox certifications in the CCBHCs if they want to take blood pressures, et cetera, et cetera. I mean, we want to do it. But how is that coming along? If it's a surprise to you, okay, I get it. But you know, we need that too.
Yeah. I play newbie card here. I don't know, but happy to figure that out and talk offline, and we can figure out what needs to be done. I don't know off the top of my head though.
Yeah, I know. I can sense the surprise. I think Jamie, you know, we used to appeal to Jamie, but poor Jamie, I think, was the last employee you had for a while. And you know, now you've moved her, unfortunately for us, into something that's probably better for you. So I will, you know, now that you're aware of the detox certification process, I mean, Mark knows about it. Those of us that have been in this business for a while, I mean, and like I said, it doesn't affect just ADAs. I think it affects CCBHCs too. And I don't know, anybody else who uses these, because I think the detox cert, when I kind of protested when it came into being, because I said it was going to be, guess what? It's going to be tough to continue it. And it is a siloed certification that can go nowhere. Well, but it went to the CCBHCs because I think it was a forced one. So anyway, if you look into it, anybody else want to say, raw, that's true, they have problems?
So
Okay,
is it just coming out of our shop? Like you're having a hard time getting anything out of our shop as regarding detox certification? Is that what you're stating?
way hard to.
Okay. That I am privy. Yeah, I will. I can follow up on that. Absolutely. Again, all of that staff has turned over like in the last 6 months or something like that. But we can absolutely follow up. And I would love more anecdotal stories from you guys on how this is challenging for you, because it helps staff understand.
Yeah, thank you. Thanks for your willingness.
Shannon, this is Jolene from Quest Counseling. I just had a question. Thank you for your report there. And can you tell us a little bit about what you did prior to this position? Like said something last meeting, but I couldn't find it in the minutes, and I'm sorry, I just don't remember.
Yeah, absolutely. Come here. I have a little one with me, so if you hear a little, he was gonna grab a paper clip off the floor. Okay. I have been with the division for 10 years officially, just a couple weeks ago. I was not on the behavioral health side though, so I came from the public health side. The last 5 years, I ran the state immunization program, so most notably through the COVID vaccine response. I was the immunization program manager for all of that. Before that, I spent some time in chronic disease, maternal, child, and adolescent health. And I also worked in community health nursing at the beginning of my time here at the division. So what I don't bring to the table is a ton of background in behavioral health and all the things that you guys know super well. What I do bring to the table is I know how this division works, and I know how work gets done in this division. And I've led a big team. The immunization program is about 60 people strong. So it's about the size of this bureau. So I've done that part as well.
Thank you so much. I think that's really helpful.
Yeah, thanks for asking the question.
We sound like we're in good hands, so I appreciate that.
Just want to say welcome, Shannon, and thank you so much. I know these are really big shoes and you've got quite a bit to do, so we are excited to have you. I am just really excited to see how you address some of the challenges that are. We've got some short-term challenges and we've got some long-term challenges, and we're excited. Know that all of us in this meeting are here to support you and help you get the work done. And we always understand that it is us versus the problem as opposed to us versus one another. So thank you for that. We appreciate it. Any other questions for Shannon? Wonderful, thank you. All right, Kendall, I think it is your turn. I saw you on earlier.
Yes, good morning.
Good morning.
So just a couple of updates for the Nevada Resilience Project. First things, all of our training as certified peer specialists and community health workers. So that's very exciting. We are also hiring some additional RAs just because we've seen that there's clearly a need for our staff. Those will be coming in the coming weeks and months. A couple of other things, we have some new paid ads that are launching for a refresh of our campaign. So you might see them on social media for Facebook, Instagram, Twitter, and a couple of third-party sites. We're taking the approach of the fact that, we're a couple years into the COVID situation. There, things have lifted, there are vaccines, but people are still struggling with mental health impacts. And so we are still here to address that, as well as additional aspects. We have some partner stuff coming down the line. Can't share it publicly yet, but hopefully in the next SAB meeting, I'll have a little more info to share. We are also meeting with the Nevada Hospitals Association next month to provide some resources to their staff. We've seen a large uptick in nurses, PAs, healthcare providers in general, really just struggling with what they've experienced over the last couple of years. And so the NVHA reached out and asked if our staff would be available to help with some crisis counseling. So we have that coming. We are also partnering with PSP Sports again to put some ads in with the Golden Knights and the Las Vegas Raiders for their season programs. So very exciting to get a little more information out there to some of our demographics that don't necessarily reach out, traditionally adult males who don't, usually think that they might feel comfortable reaching out to mental health, but unfortunately they are one of our highest suicide rates. Some not necessarily Nevada Resilience Project, but just mental health things that we're working on. We have submitted a proclamation with the governor's office to make May Mental Health Awareness Month. That was approved yesterday, so we'll have a proclamation coming out from the governor's office. And then we are working on some educational videos to address the process of crisis holds for youth and adolescents in both English and Spanish. Those are being filmed next week and will be shared next month in connection with Mental Health Awareness Month. They are for providers, they are for hospitals, they are for the general public. So if there's anybody who's interested in getting copies of those videos, once they're done, please let me know. They're brief 4-minute explanations of how mental health crisis holds work in the state, since we know that can be kind of a confusing process for a lot of people. So myself included, I had no idea how those worked. So that's kind of it for now. But like I said, we'll have more announcements coming in the next meeting. But if anybody has any questions, I am here.
I have Kendall. You and I have spoken, and I have some questions. Does any of your staff refer to the treatment centers, to the CCBHCs, to open beds?
Yes.
Okay, so you don't do it though in rurals. I mean, we operate in Carson, Dayton, Reno, and Elko. I just don't know if we get any referrals from you, either through open beds or through your staff directly calling us up. So can you give me some insight?
Yeah, of course. So we do share referrals to those who reach out to us. The way the NRP works, though, is traditionally it's up to the client to reach out directly to the provider. We can do warm handoffs if that's requested. It honestly usually isn't. So we are sending people to the CCBHCs, and we did a open beds training 2, maybe 3 months ago for our staff, just so they know how that system works on the back end. But you wouldn't know the NRP is sending people your way because it's the client reaching out to you directly. Very rarely do they ask for assistance with warm handoffs. If they do, we obviously provide them, but it's not very common.
Okay, so you have information about all of us throughout your system, you know, north, south, so that you're aware of the breadth of services that we have.
Yes, yeah, we actually have an internal documentation that explains what all of the CCBHCs, where you're located, what you offer. And we've had a couple providers over the last 2 years, you know, express interest in talking with our staff and doing presentations if they want to give a refresher on what the provider does, and we're always open to that. But we do make sure that all of our team is aware of every CCBHC and what you guys offer and what you provide, so that they can send people to you as appropriate.
Okay, so how do we get a hold of you now?
You can just shoot me an email. I'll put it in the chat, and we can, if you want to set up a time to talk with me or staff or anything like that, we can absolutely do that. Like I said, we've done it with a couple people in the past, so.
Thank you, Kendall. You've been real gracious. Oh,
Yeah, of
we'll be talking.
course.
Any other questions for Kendall? I actually have one question. Kendall, you mentioned that your resilience ambassadors are being trained as peers and CHWs. Peers are required to have the lived experience. So what training are they getting, and what CHW training are they getting?
They're being trained through CASAT. The CASAT program, that's my understanding, and Shannon might be able to touch a little bit more on that, or even Michelle, since I know you're on here, in terms of what that training encompasses, or even Dawn. But my understanding from what I was told this week is that all of our staff is going to be trained through CASAT for certified peer specialists and community health workers. I personally am not familiar with what that entails, but I can find out a little bit more if you like.
Jamie, I can jump in if you would like me to.
Absolutely. Thanks, Michelle.
Great, thanks. So for the resilience ambassadors, it was requested that they go through the fundamental peer training. So not necessarily moving forward with complete certification, but at least getting the basic concepts of what a peer would do in this particular setting. So they would go through the 46-hour online training, and then also have access to a supervisor from our side to help with debrief of what that training entailed. Those that do have the lived experience can go on to certification after the practical hours are completed. And then it was also requested that the resilience ambassadors also participate in the community health worker training, and that is done through Healthy Communities Coalition, I believe. And so I had the opportunity to go through that training, and looking at it in comparison to the peer recovery training, it does help promote additional note-taking and charting. So I do think that those two concepts, peer recovery and then the community health worker, really just help to bolster the services that the resilience ambassadors can provide.
Thanks, Michelle.
Thank you, Michelle. Yes, that's helpful. So they're just going through the basic peer and CHW trainings.
Correct.
So Michelle, community health workers do not have lived experience.
Correct, they do not.
Okay, all right.
But to follow
Okay,
up on
we
that,
just-
community health workers do help to promote services and how to refer individuals to particular services. So they will go through and provide an assessment, whatever assessment is used by the particular organization they're working in. And then from that, help to identify what additional follow-up services to link that particular client or individual to. So their linkage to care is more for primary care services.
So Michelle, are they bachelor's level, and can you get them paid by Medicaid?
They could be bachelor's level, or they could be grandfathered in from having provided the services in the community prior, and they are reimbursable by Medicaid.
Really? Even if they're not bachelor's level?
Correct.
Yeah. Interesting. Thank you.
Wonderful. All right, Kendall, I think you are off the hook. And
Sounds
now
good.
we move, oh. Okay, and now we move on to Tracy to give an update on the SAPTA Advisory Board, NOFA, and the Synar rate.
Hi, everyone. Sorry, I was trying to click the mic. It's always fun to remember that I need to click that off. So yes, Tracy Palmer, Health Program Manager here with the Bureau. And I had added a lot of different items as to some areas I would just wanted to touch bases on. I'll be able to also help provide a little additional information regarding, for example, the certification and some of the questions that had been asked to Shannon. But one of the, so I've staffing seems to, as you all have heard, has been a trying time. At the same time, I just wanted to kind of let you all know who has come on board, and we're very excited. So for the prevention team, for about almost 2 years, Ben Trevino was the prevention administrative assistant. He also has been working with several different entities within our Bureau, whether it's working with the treatment team or the prevention team. And so he has been promoted, and he is our substance abuse primary prevention state general fund health program specialist. And so we're very excited to have him on board. He's very familiar with the coalitions. He's very familiar with kind of the ins and outs operations and subawards. And so it's been great to see him expand in his knowledge. He is also hoping his long term is also working towards in the treatment side of the house. I'd like to try and keep him on prevention, but you can't keep them down when he wants to keep going. So I'm excited to have him on board. In the treatment team, and some of you may or may not know these folks, but I wanted to just kind of, from the point of when I was asked to take on the treatment side of the house, it also brought in other new staff who had only been here for maybe a month and a half. Not to say that they don't have experience in the treatment field, but they definitely were working to, gain their knowledge with the state. And so with that, Dr. Jennifer Tongle, she is one of our new health program specialists. She is going to, and she has taken over the FAST and MOST and the 8th Judicial subawards in that area. We have Abigail Hadafy. Abigail is taking over women's services. Then we have Denise Williams. I think she's been with us for about 4 months. Denise has been handling our state general fund treatment subawardees, and then to talk about the certifications, we have transitioned from Jamie, who, yes, had it for several years, and we plan to continue to kind of have her in that hidden background if we have questions or concerns. But we have asked LaWanda Jones. She is just hitting our 1 year. So she has some really good background in understanding of the work with the subawards. And now she's going to be our health program specialist that's going to focus on certifications. We have done intense training with her and the treatment team. One of the key areas that I believe in is having that backup person. And so the entire treatment team has learned how. They know the ALIS system. They have been trained on the various certifications that are needed and required. And so LaWanda is focusing on that. And are working towards getting all of these certifications up to date and taking that load off of Jamie so that Jamie Frederick can move on to her new position. And then also we want to be able to get all of these certifications up to speed. One of the things, for example, as you guys were talking about certifications and the Detox Certs, we currently show we have 4 Detox Certs in the queue right now. So that's awesome. And it looks like most of those are, I think, with Churchill area. So I'm excited that we're starting to really look at these, get them taken care of. And we've talked with Mark quite a bit. We have let, and then also we've had training with Michelle as well. So we have dove heavily into that area, and we're hoping within a month or 2, we should have them all up to date, if not sooner. Also, the next person on board that I'm excited is we have Jerry Manning. She is our new treatment team administrative assistant. And then also Jerry has state history as well. So I'm excited. She has been a great asset to our team. And then our newest member is Stephanie Cook. Stephanie Cook is our new health program manager 1, and she will be assisting me, and she's going to be overseeing the treatment team. So we have a lot of hands on deck to help get some things in order and to be able to have back to having staff focusing on their primary areas, but also knowing how to back up somebody. If I like to say, if you ever won the lottery on me, how can I be able to pick up your job and, handle it going forward? And so having that backup and support has so far been very beneficial. Okay, so that's our new staff right now. In a couple weeks, I had to look at my calendar, we will be replacing Ben's position in the prevention, but like I said, that'll be for another couple of weeks. I don't see any foreseeable changes right now when it comes to the treatment and prevention team. We do, like Shannon had said, though, we do have some other ideas that we're working towards to make this a much more solid foundation. As of April 7th, Ms. Shannon Bennett and I had a meeting with Sheila Lambert and Don Yohe, and we basically went over the knowledge transfer of the notice of funding opportunity. So that's the NOFO. And we've been working within a very short time frame, but we've been working on taking over this project. So just so that everybody is aware that that is something that we're having that transition where it's coming over into our hands. And then we're currently finalizing any remaining eligible applicant subawardees that need to be addressed. We are having, we're still working with the primary folks who did the evaluations. And then one of the other key elements that I had heard, not only from today, from you, David and Esther, but also from some other entities that had applied. One of the things that was mentioned that there is ongoing efforts to help not only our community members, but those who serve the community. So out of this NOFO was the discussion to develop a focus group, and that it'll be not only developed, but to be implemented in focusing on provider standards. So I'm hoping that those who feel that there needs to be some bigger changes in having the opportunity to be part of that, please let us know. We definitely would welcome that. And like I said, I know and I support when Shannon's talking about, having input, and from this being an advisory board, it definitely would be great to have a few folks be part of that focus group. So we have one of the other things that I just wanted to mention. There was a little confusion where there was some notice of funding opportunity awards that came out of the governor's office. That was a separate funding opportunity than the one that was being handled through the Bureau. Through that, though, the Bureau has taken on one in the prevention area, and I think we have up to 4 in the treatment. I'm not sure all these numbers are finalized, but I just wanted to share that with you folks that there are, several funding opportunities that have happened, and so the Bureau has taken on some additional funding sub-awards, and so we're working really hard to have this very organized fashion and making sure that we have that clear foundation as well. So that
Tracy, I apologize. You're talking about NOFOs and you're talking about focus groups, and there are at least 5 major grants out right now. Can you clarify what NOFO you're talking about?
So the notice of funding opportunity, the treatment NOFO, and that is the COVID-19 supplemental dollars, and then there is the American Rescue Act dollars.
Okay, so you're talking about what I call the ARPA extra block grant dollars, and then
Yes.
the governor's funding, the governor's additional 30 million, because they're both $30 million pots of money. You're speaking of both of those?
Yes.
Okay. And
Yep.
so are you announcing what treatment agencies have been funded?
I am not announcing because I don't have a final list. I know that people have been receiving letters. Don Yohe did send out a notification, an email that went out on April 7th. And I know that people have been informed. But I don't have the final because that wasn't, we just don't have that yet.
There was a list that was sent out. You're right. That was Esther. But you know what I find? And we were given an oral interview and that they kept talking about the powers that be. And I said, who is that? They said, it's a secret. I said, really? Actually, I've never heard that before. Yes. And I said, oh, yeah, nobody knows, or you can't know, nobody knows. And I thought that was really new. So anyhow, this is quite a process, and whoever the powers that be are secret. So, but anyway, the list is out because I've seen it, Tracy. I can't tell you. I think I see some of our partners, our CCBH, one of our CCBHC partners is on the list. I don't know if you are, Jolene, whoever, I can't remember, but Lana is, because I've seen that list for one of them anyway.
Esther, but you don't remember where you saw that list?
In my email.
Okay.
Do you want it? I will try to track it down, so wish me luck. And I will try to track it down and send it to you. And okay, so it's T Palmer where?
At health.nv.gov.
Okay, T Palmer at health.nv.gov, the same as Kendall.
Yeah.
Okay.
Yeah. And there's one of the things, and I know that when they say secret, when they have and this is just a slight sidebar, but I don't want to get into the details of it. But during evaluation period, that is a confidential process, and it's just to prevent any bias. And that's during the time frame of when all the evaluation's going on. But in respect to the list and so forth. So I appreciate, Esther, of you sharing that so that I can at least make sure I have it. Like I said, Shannon and I were receiving this kind of the knowledge of transfer, and then we're getting all the other transfer of information because we're taking over the project. So
who was with Don Yohe? Went for the oral interview? I can't remember, Tracy. It's a name that I've heard, but I can't remember because I don't think Dawn said it. She was pretty quiet. It's the other one that said it. I can't remember the lady's name. Anyway, okay, so, but it's not a secret. I just don't remember who it is.
okay, well, that would be great if you could send me that list. I would love to have that ahead of time. I'm sure at some point I will be getting it, but thank you. And am I okay to move forward?
I wanted to call attention to the chat, and there have been some questions answered in the chat by Elise Daniel Woodard. Yes.
Okay. 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 So thank you for those who are helping and answering some of these questions that I may not have the answers to. So in moving forward, one of the other areas I wanted to share is that the Synar Act, and that is your prevention tobacco sales to youth. Nevada, because we accept the substance abuse block grant dollars, then we are expected to comply to the Synar Act. And the Synar Act has set terms and conditions, and the state has received a retailer violation rate. Sorry, I had to think for a second. So the Synar Act and the state violation rate right now is pending with SAMHSA, as in if we are moving forward with our penalty. Because all states are required to have that 20% retailer violation rate, and Nevada hit 30.4%. SAMHSA had applied and due to COVID, due to our shutdown restrictions, SAMHSA was not able to. And Nevada had already started work towards addressing these addressing the high violation rate. With that, SAMHSA has gone back to our grant project officer, I should say, has appealed and gone back to their administration and has shown the different actions that we have already put into place and what we've already developed to alter and change this violation rate. So that's why I say it's pending status. We hope that SAMHSA will agree to this request from our grant project officer, and they will drop the penalty. It doesn't mean that we stop doing, moving forward and making the changes. It definitely means that we won't have a large penalty. The penalty is usually, it's either 40% of your block grant dollars are removed, or we have to pay back an X amount of dollars. So you can understand why it's very important that we, hopefully this penalty is dropped. But that is a pending status. It's something at SAMHSA's level, and but it was a status I wanted to bring up to date. I think I was mentioned a couple SAB meetings ago, but I just wanted to make sure that folks were aware of that. The other aspect to taking on block grant dollars and having this, complying to the Synar Act, we have to conduct every 3 years a Synar coverage study. So the Synar coverage study entails going out to random selected regions of Nevada and verifying availability and tobacco access to youth, or if it's not available to them. And we have several community partners assisting in conducting this coverage study. And I'm just excited that we're in the midst of getting this done. We have Jenny Bear, who is our health program specialist. She is over the block grant program here in the prevention area, and she is working directly with our tobacco control unit, and she's slowly monitoring that aspect. The goal of having this coverage study completed is by June. That gives us enough time to gather the data and write the report up and be able to have that ready for submission. And then last but not least, I just wanted to share regarding the fiscal prevention monitors. We, again, unfortunately, due to the pandemic, we lost actually almost 2 years now of conducting fiscal. So sorry, I'm seeing all these different communications in the chat. It's a little distracting to those who like want to read everything. Okay, so the fiscal monitors were not conducted. And so with that, we're picking up finally. Several providers have already seen or received requests to submit information for fiscal monitors that are being done either by strategic progress or by a state entity who is doing the random fiscal monitors. So I just wanted to thank everybody for working with either person that you are having to submit your documents to when it comes to having these monitors. I know it's cumbersome. I've worked in the private sector before, so I know it can be a lot of work. At the same time, it will help us in the long run, and we're making sure that we're doing our due diligence and following our terms and conditions that we have to comply to as well. And with that being said, I'm happy to answer any further questions. It looks like in the chat there has been a lot of answer and discussion, so thank you to all of those who have been answering questions on the side.
Tracy, did you see that they sent it to you? I thought that
I did see a bling.
is that, I think that's what you want, isn't it? Otherwise, just tell me, is that what it was that they sent it to you? You're fortunate. Okay. All right.
Are there any other questions or anything that I may answer, or otherwise, if there's additional certain topic areas that you'd like information on? Oh, I'm so sorry. I do have one other area. We are sending out, and we have sent out for the State General Fund subaward templates, subrecipient questionnaire templates. If you need to update them, we're trying not to send it out to you if we see that yours is updated. There is the Section C of the budget narrative that also has to come in with the sub-grant template. These are all going out to those who have subawards that are state general fund dollars that start on July 1st. And I'm working with the treatment team as well. And so we're trying to make sure that we get these out to everybody so you have plenty of time to get everything established. I know the prevention coalitions have their actual fiscal dollars. The treatment team people don't have the exact dollars, but we will. I'm working with Stephanie Cook, and we are at least making sure you guys get your templates, and that we will, as soon as we get the final numbers, and making sure what is an allowable dollar amounts. So I'm trying to think if there's anything else for the state general fund subawards. If for some reason you don't hear from myself or from Stephanie Cook, please reach out to us or to the program analyst and saying, hey, I haven't seen a template come my way, and you normally get one. Your patience is greatly appreciated, and as we kind of make sure who is handling which areas, and then we're making sure that we do reach out to you.
And it looks like Jolene has a question.
Okay. Yes, ma'am.
Thank you, Jamie. Tracy, my question is, because of our high violation rate for tobacco sales to youth, you said, I believe you said 40% of the block grant dollars are removed. What amount is that? What amount of funding is that?
So I said it could be, that's part of the penalty. There's two different penalty routes or decisions that can be taken. You can either choose to have 40% of your block grant dollars removed, or reduced, I should say, or you have an X amount of dollars that you pay to correct the penalty, but you cannot. But it is a estimate of the, well, it depends on the choice. And then it also depends on the dollar amount that the state was awarded in the year of that penalty. So for example, we would look at what was the block grant dollars awarded in 2019. And then we would have to calculate 40% of that. And or we would have to pay, I think we came out with approximately between 1.2 and 1.9 millions towards fixing the penalty, but not using block grant dollars. So SAMHSA gives you a choice. The problem comes in is when you look at which, so you have to look at the year, and then you have to figure out how that methodology is going to calculate. So we don't have an exact dollar for the simple fact that they may not even apply the penalty. That's why I said it's in a pending status, because we do not have an exact dollar amount, and we haven't been told by SAMHSA a dollar amount, because they're trying to decide how they're going to handle it. And the best part is that the grant project officer who has been working with us was promoted and has known Nevada for the past, I would say, 10 or more years. And so she has been able to say what a great job Nevada has been doing and how we've been working towards fixing this problem.
So Tracy, can you tell me what the proposal that Nevada put forward to address the 40% reduction is? Because obviously you guys had to say this is what we'd like to do. Can you tell us what your proposal was?
Yeah, our proposal was that we would rather put state dollars towards adjusting and working towards fixing the reduction, the retailer violation rate, than to have the 40% reduction of the block grant dollars. Because it was, yes, it would be much easier and less costly to do it that way.
Thank you.
I'm hoping it completely. We were told in our last SAMHSA meeting that it definitely was looking towards like a minimal corrective action and showing them everything that we've already been doing since we saw this problem.
Wonderful. So, and thank you. That's helpful. So where, because, and again, these are very, very, very basic numbers. And Mark, I know you, because you and I spoke about this ages ago. Isn't it about $16 million? So whatever 40% of $16 million is, isn't that what the block grant would have been?
You know, and off the top of my head, I do not remember when it comes to 2019.
And I
Because
think it's
that's
around,
the, so, yeah, you have to look at the year of that block dollars.
So what are the plans that SAPTA has for what state dollars would be used to, what state dollars are being spent to correct this problem?
Haven't been given the direction from SAMHSA. And until we're given that, then fiscal isn't making any final decisions. Maybe state dollars.
Okay.
So I don't have that answer for you.
Okay, thank you.
This is Leo Magardichin. I just kind of have a question. So this is 2019 that we knew this. Can you be a little more detailed on some of the efforts that we're doing to address it so it doesn't happen, or they don't go back and look at 2020 and 2021 and continue to take block grant dollars for us, or at least threaten to do so?
Yeah, actually, that's a great question and comment. So you are correct. Part of the concern was the state did not receive the penalty letter until about 2 years later. So we had no idea as to our status. We were not aware if we were going to get a penalty. We didn't know for sure how they were going to evaluate the retailer violation rate. In the meantime, we knew on the surface here at the state that we were looking at a potential penalty. So with that being said, I immediately requested that we put together a Synar strategic plan. So we developed in collaboration with the Tobacco Control Unit and with our Synar coordinator and with other like our IT staff. We had a group, and it was also with the Attorney General's office. So we had various folks who attended a focus group and put together a strategic plan. And this encompasses, I believe we have it about a 5-year plan. It talked about the current situation, and it talked about some of the changes that we can do going forward. I believe that's also on our website. So I think if Ben Trevino is on the call, he might be able to plug that link in there for you. So if any of you want to read it, it is out there. We also developed a logic model. And so again, that pulls in the key performance measures. It pulls in some of the different elements that we will be addressing and plan to address. One of the other areas of pointing out is having that Synar coordinator. That person kind of keeps the pulse on what's going on and makes sure that we're heading in the right direction. We've also increased, and that's one of the areas of increasing by education and awareness of what's happening. We have also been in deep discussion with the Tobacco Control Unit and finding out some different ideas of what we can do other than what we've already been doing. That is another thing that we're looking at. What has been happening? What happened in 2016, 17, and 18? And unfortunately, this is one of those things that we're looking at after the math, right? We're looking after when the penalty hit, we're already 2 years down the road and we get the letter. And then luckily in that time frame, it's like, okay, well, these are things that we've done. And I'll try not to get too detailed, but the other area in Synar annual report, there's a section B, section C. In those sections, we were able to look at how are the inspections conducted. So we were able to adjust the methodology and look at, because Nevada has such a large rural areas. So we were able to look at the how the inspections were conducted. We were able to do a few adjustments with how we pulled the numbers, the random selection, and all of the different elements. That's about 4 different items that we really did differently. And then I would say the 5th item was making sure that we have someone who is solely focused on Sinar and understanding the complexity of it and how we can actually continue to work towards reducing that violation rate. Working with the retailers, at first, there was a lot of negative type focus, and the goal was to look at it from a positive focus. Why not focusing on some of those who are doing a great job and carding and checking and recognizing them. And then there is also listing those who received a penalty, those as in a retailer who does sell, putting them on a list and showing that out, on the retailer association and talking to them. So there's a lot of different performance improvement concepts and projects that are currently in motion, I guess, better way of saying it. But definitely when we submitted the annual Sinar report last year, we had the 2 different sections of the report showed that we had adjusted those 2 areas. We also uploaded the logic model and we uploaded the Sinar strategic plan. SAMHSA was very pleased to see the Sinar strategic plan, logic model, and that we had already made the other 2 changes. So with that, the final product that's remaining is the performance improvement plan. And that is pretty much aligning with everything I just said, just putting it all into a written narrative of here are all the different items that we are doing and have done since we found out that we hit that 30.4%. There are multiple states that are way under 20%, and they have high rural areas. And so we have to, we've done a lot of discussions with other states as well. So yeah, there's been a lot of different work that has gone into trying to figure out what can we do different from where we were, and just showing and letting SAMHSA know this. They've been very pleased with several of the activities and the outcomes. And luckily, with that being said, our retailer violation rate was lower. It wasn't below the 20%, but it was, Jenny Bear might have to type it in. I want to say it was like 26.4, but I don't remember exactly. So we have already reduced, which is awesome. So to your point of what happens when we keep being over, the point to that is SAMHSA passed this regulation that allows states to bring in the regulation of tobacco 21. And because they know a lot of states didn't have tobacco 21 in the regulations, then they allow a 3-year transition. Our legislative passed the tobacco 21. So that was nice. So that helps us getting towards that education and awareness, and the selling tobacco under age 21. We're hoping that will also help towards this violation rate.
Tracy, I have a question. Has it been thought out to maybe do something progressive with the retailers where they end up just losing their license to sell it? Because, I mean, there really isn't a stick any of us have. I mean, we do have the education pieces, but it just seems like there's really not a big enough stick. And I mean, that's the big stick really is, well, you can't sell it. So I just didn't know if any other states have even done that fully or any.
No, that's a great question. And it's one of those things that we definitely have talked about applying a penalty. So if you're, you get a penalty, you get a letter saying you've been caught selling to a minor, because when they go out and do inspections, there's that, you were going to sell to this minor. However, the Tobacco Association, the tobacco company, is very big, and they have a big pull. And so applying a cost penalty to them or removing their license has been not approved at this time. I think that we are close to being able to maybe apply a cost penalty, at least saying, whether it's $100 fine or what have you. But right now, that is pretty much our next step. Removing the license would be this large step. But unfortunately, yes, we have not been able to get that all the way. We haven't been able to push that request. It is an option. It has been brought up. I know it was brought up during last legislation of some of the penalties or some of the ways that we can work with retailers. I see a hand up for David.
Yeah, hi. Hey, when it comes, I find it ironic that there's no penalties at all for that, considering what at least the Clark County did. I'm not sure if the state did it as well, but they were fining businesses if people walked in without a mask. And or if you serve somebody without a mask. And I don't know what those fines were. As somebody who cannot wear a mask, it caused me hell, because I couldn't go into those stores because they were worried about getting those fines. So it's interesting how quickly we can get attention when we want to do something like masks. But when it comes to the smoking with our kids, it's something else. I would be totally opposed to taking their license away, though. That there's some re-education stuff that would, just imagine what it would cause to the banking and to all the employees, because the bankers have loans on those buildings and such. So that would be a major thing that I'd be opposed to. But the penalties, like, absolutely appropriate, I think. So just a thought.
Tracy, putting it out in the public that somebody violated that. I mean, here they publish when sanitation goes into various restaurants, and the scores are posted so people know who's violating public health standards. And I wonder if that could be one of the deterrents, is that it's published that you violated the law for underage tobacco use.
Esther, I think that would be a great thing for all the kids to learn about, because they would go to those stores more regularly.
Oh, great. And you're speaking as a banker too about the other stuff, for God's sakes, David. So I want to say one thing. I was vacillating, but I'm going to say it. Do you know that years ago, they used the Synar Amendment to exclude tobacco use in treatment centers? And I thought, the Synar Amendment. Well, one day I read it. It was for underage tobacco use, but SAPTA, beta tobacco use. So is it a good thing? Yeah, but I think it should have been probably stated that it's not the Synar Amendment. And then we put the stop tobacco programs into these treatment centers. What Beta just said, keep the tobacco out. Good thing. But then we did the stop smoking programs. That was the best thing. So I just want to tell everybody that, it's anyway, there's a history on this Synar Amendment. And Tracy, I need your phone number.
775-684-4069.
Okay.
And from a advisory point, I do appreciate the posting violation on the windows. And then we do have the ability where it is posted on when a retailer violates, then they are able to be on a list for the Tobacco Association. I know that we had tried to put it out where it would be posted publicly. I don't know exactly where it would sit in the aspect of showing youth or showing someone who, lack of better words, showing other people who, you know, is violating or selling to their kids.
I think to me it's a watch list. It would preclude them from going there because they know they've already been in trouble and they may be on a watch list. So there, David, take that.
Thank you for your input.
Any other questions for Tracy? All right, thank you very much, Tracy. Elise, tell us all about open beds, please.
Hello, SAPTA Advisory Board. Elise Monroy here with the Overdose Data to Action Program and Open Beds. We've been added back to the agenda as a standing item to provide regular updates on the system. Sorry, I got something in my eye. Been sitting here with no issue for 2 hours. Sorry, guys. During the last advisory board meeting that well, first I've got an update on some of our network activity for March, and then I'm going to talk about some of the issues that were brought up during the last advisory board. So in March, there were 337 referrals sent through the network. That was amongst all of our referring providers. Crisis Support Services is still the leading referring agency on the network, but we've been starting to see an uptick across the network with hospitals and other community-based providers sending referrals. In March, as of March 1st, Northern Nevada Adult Mental Health, or NAMS, has changed their process to now only receive referrals through the open beds system. So historically, they've gotten referrals through the phone and through fax and probably email. But to streamline the process, they are, as of March 1st, they're taking referrals through open beds. So we've seen just kind of an uptick in activity. Something we've also seen kind of a big spike in March. So we're looking at a really high number of declined referrals. So for the last year or so, we've seen a lot of referrals sit, but only a couple of them get declined. So as an example, and I don't have data, I want to make sure that we have good quality data to present to you, and we think there may be some reporting issues, but in months prior, we have 200 referrals sent through the network, 190 stay open, and then 10 are declined. That's kind of standard activity. In March, we saw 30 referrals come through the network decline. So that was a really big increase. Most of the referrals were declined for insurance reasons. So we're wanting to make sure that as our receiving providers are kind of continuing to work through learning how to use the open beds tool to take referrals, that everyone's configured services and payers are up to date. So we'll be reaching out to everybody to make sure that our records are appropriate. You know, I know that sometimes providers come in and out of insurance networks. Our vendor was supposed to be doing a quarterly check, and I don't think that happened. So we are putting those processes in place. And then I have 2 follow-ups on the data quality issues that were brought up during the last meeting. So during the last meeting, there was a long conversation about multiple agencies working referrals at once. And there were concerns that multiple agencies were spending time on referrals, trying to get the same person at the same time. So we kind of have pinpointed this issue back, kind of referrals not being accepted or denied when they come through the platform. Typically what happens when a referral is sent through the platform, a receiver will accept that referral or deny it. If the referral has been accepted,
The other providers that have been sent a referral will get a notification. So let's say I've got Esther and Jolene on my screen. So I'll say if a referral was sent to Quest and to a Vitality facility, if Quest picks up that referral, the Vitality facility will be notified, Quest accepted this referral. But it looks like what's happening is because referrals are not being immediately accepted, there's a lot of back and forth communication with the referring site. So Quest or Vitality will be communicating, let's say, with crisis support services about the patient, and nobody has gotten that notification. So we are working with the vendor to understand how we can make sure we don't create a situation where both Jolene and Esther have staff working to grab the same person at the same time. So that is in the product, or that there's notification, let's say that like Jolene is communicating with the referring provider, and so Esther knows that. So we're working on that. And then I'll take questions after this, but there were also concerns during the last meeting that there might be an issue with how we're reporting on the time to acknowledge. So ideally, we would want referrals acknowledged within 30 minutes. So the referring provider isn't sitting with a patient for an hour or 6 hours or 3 days. And it sounds like what's happening is there was a concern that the referrals were being worked on and that wasn't being clocked in our system as acknowledgement. It is. So our time to acknowledge clock, so let's say in minutes, so the referral is sent, the clock starts. As soon as like Leo at West Care, someone on his staff would pick up the referral, that time clock would stop. So that's the time to acknowledge. So we're still seeing referrals sit for a long time. But I think maybe once we get the issues with the multiple agencies working referrals at once, it might increase receiving providers kind of, I don't want to say willing system. I know that if I was on your guys' end and I get a referral and I think, well, 2 other people are probably working this, I don't need to touch it. I imagine that's a challenge. So we are working to address that. So lots of product stuff we have to work through, but we're working through it, and we wouldn't know these things are issues unless you guys brought them up. So I just want to say I appreciate that. Are there any questions, comments, or concerns? I wore my shield and armor today, so I can take anything.
Are these inpatient or outpatient declines?
It looks like I will have to go through the list here. I don't have anything to show, but it looks like most of them are inpatient. Like I would say 90% of them are inpatient, and most of them are related to insurance issues.
Are they pure psych, or are they co-occurring? Are they SUD?
So that's a really good question. How we have the services configured in the system is just by receiving service, and it's inpatient psych. I think we don't have it broken down by like level of care. But for the next SAPTA advisory board meeting, I will have cleaned up data to show you guys so you guys can see what we're seeing. We had a delay getting this from our vendor, so I couldn't get stuff nice and tidy to show you guys, but I'll have that for the next meeting.
Right, because at least we can't help you. I mean, those of us who are on the SAPTA advisory call, we're co-occurring, but we can't, we have to have an SUD diagnosis. So we want to help. I know we all would like to help. So if we can provide some facilitation, let me know, and then we'll just chat down the road.
Okay, perfect. And it could be that we need to have our configured services different. I do see here we have inpatient psych, which I'm thinking is just general mental health. And then we have another configured service for as a separate service. So for the next meeting, I will bring a list of our declines, reasons for decline, and then our configured service, so you guys can kind of see what we've got going on. I will say network activity has like really picked up in the last couple months, and that is in large part, I mean, it is you guys, it's the receiving providers picking up referrals. So I just want to say thank you. I also just want to say, and this is maybe like minorly out of my lane, but there's just a lot happening right now in the state around preparation for 988. And there's going to be some like pretty big system changes over the next couple of years with how people are kind of moved between treatment and how they get there, and figuring out how we can support you guys in using a system like open beds will get everybody in a better position to be able to handle referrals that may be routed through a 988 system. So I just kind of throw that out to think about. I'll put my contact information in the chat, and Miranda and I are here to provide any sort of technical assistance and support.
Any other questions for Elise? I just want to say thank you again. I know oftentimes you get a little bit beat up when you come to these meetings, hearing all of the frustrations from providers, but the fact that you come with solutions after every set of frustrations, really refreshing and so appreciated. And your ability to show back up and say, look, we're trying to fix the problem is just absolutely wonderful. And so thank you for not hiding from us and continuing to work with us. We really appreciate you.
Chairman Ross, I have to ask Elise something. I was wondering if we could get a report from her down the road about the committee on which she sits that is going to be allocating lots of money. And you were you really made some good points because I was on that meeting. So I think we need to hear more about that committee and what's going to happen. And it's an acronym committee. I'm sorry. What is it, Elise?
ACRN.
That's what I say that, but I didn't want to make a mistake. ACRN. So could you tell the group what it stands for?
Yeah, Jamie, do you mind if I answer? Okay, so this is Elise Monroy for the record. So this is the Advisory Committee for a Resilient Nevada. The acronym is ACORN, and whenever I talk about it, I have an image of, have you guys seen Ice Age, the little squirrel with the nut? That's what I feel like. So it's ACORN is what we lovingly call it. And the ACORN is the committee that has been put together that will make working through a needs assessment process and make recommendations for how the state is going to subaward out and make grants to the community about or with the opioid settlement dollars. So this is like a really complex process with funding. I think there are a lot of people that are looking, and I was too, was kind of like thinking back to like the last big settlement, which I think for the state was tobacco. The state had a lot of lessons learned from the tobacco settlement, so they're wanting to kind of establish a better process this go around, which is kind of how we ended up with the ACORN. The ACORN was set out through Senate Bill 390. I would encourage folks to go back and look through Senate Bill 390 because it clearly lays out like what's in the purview of the committee. And then it also lays out like what has to happen, some steps that have to happen from the local level in order for communities to get funding from the One Nevada agreement. So I am happy, Jamie or Esther or committee, to come back and give a report out as a committee member. I'm comfortable speaking to like the work that's going into developing the needs assessment, how the committee is guiding that process. But I think it would be really beneficial the DPDH opioid program in the director's office or the attorney general's office to come and talk about the how the funding is going to like kind of trickle down into the state. But I will come and talk on whatever. I just think it would be helpful to have someone who can talk about how the funds trickle down. It will be helpful.
Okay, thank you.
Thank you. And Dr. Woodard said that Kendall is going to provide an ACRN update. So we can definitely have that conversation next time. Wonderful. Thank you so much. All right, let's go ahead and close that agenda item. And CASAT, is that going to be Mark or Michelle, or are you guys going to tag team?
Tag team, you want to go first, Michelle?
Okay, so CASAT is on the agenda. What do you want me to give a complete overview over SOAR, or do you just want me to jump to naloxone and fentanyl testing strips?
I think naloxone and fentanyl test strips are probably a little bit more germane, and then maybe we can do a specific agenda item for the next SAPT advisory board with a little bit more detail. Because I know you got asked to do this like 4 days ago. So there's probably not going to be a ton that you've got ready to go.
Oh, I prepared a presentation. Mark had indicated that you had spoken to him asking to do a SOAR overview. So I do have that ready, but it is lengthy. So I just wanted to see where you wanted us to start.
I'd say let's go ahead and start with naloxone and fentanyl, and then we'll see if we can do the SOAR update at the next meeting. Is that possible?
Absolutely. Okay. So naloxone distribution, previous to the September 2021, there was two main mechanisms for the distribution of naloxone throughout the state: the SOAR grant and then the First Responder Care Grant that was held with Southern Nevada Health District. The agreement was that Southern Nevada Health District would provide naloxone to the entirety of Clark County and to all of the partners that partner with Southern Nevada Health District in whatever mechanism they wanted to distribute. We did collaborate on the distribution manual and on the training. So the training that everyone receives statewide for overdose education and the data collection is all universal. And so when the First Responder Care Grant ended, it was asked that SOAR pick up all of the rest of the naloxone for distribution throughout the state. And so we have been trying to meet the demand that Southern Nevada Health District has, but it has been difficult to get the units distributed to them. So we ordered 7,000 units in September 2021. Southern Nevada Health District, I guess to back up a little bit, goes through an average of 1,500 to 2,000 units a month. And so to make them whole, they need roughly 15,000 units to distribute. So we have been trying to push this forward, but we can only purchase up to the amount that SOAR has available within the particular funding stream. And so in September 2021, we ordered 7,000 units. In January 2022, we ordered 5,000 units, of which we distributed 2,000 to Southern Nevada Health District and then 3,000 to the rest of the state. And on March 17th, we ordered an additional 10,000 units, which should be arriving next week. And so with that, we will be also distributing to Southern Nevada Health District. So we've spent roughly over 1.2 million in naloxone. And so we are hoping that we can place another order and really provide this service to Clark County. So I think that if we're looking for all intents and purposes, and this is a conversation that we'll also be having with the division and the new project officer for SOAR, to get Southern Nevada Health District to where it needs to be, we'll need to order them 10,000 units to get them through the end of September. We'll order another 10,000 units for the Nevada for actual SOAR. So we'll be looking at placing an order for over $1 million again. All right, fentanyl testing strips. So again, there are two mechanisms for the distribution of fentanyl testing strips. So Southern Nevada Health District has the OD2A project, and SOAR has the project that will distribute to the rest of the state. With fentanyl distribution and education, what SOAR has targeted is harm reduction organizations and needle exchange programs, organizations that engage in street outreach and work directly with high-risk populations, law enforcement, first responders, existing naloxone distribution sites. And our project was to launch in March 2022 for a full project launch, which we have done. And to date, we have distributed 3,000 fentanyl testing strips through SOAR. With the Southern Nevada Health District project, I only have data for what was presented during IFC in February for them. So they launched their project in December 2021, servicing Clark County. They have 32 stakeholders from 6 agencies that completed their particular training, and they have 4 distribution sites. And as of February 2022, they've distributed 2,400 distribution strips throughout Clark County. So for SOAR purchased fentanyl testing strips, so anything outside of Clark County, you can order them directly through the SOAR project and we'll ship it to you. Let's see. What else would you like to know, Jamie?
No, I think that's helpful. So I'm curious. I know some of our treatment agencies are also, as they hand out naloxone, they're working to hand out fentanyl test strips. And I would encourage those who are in treatment agencies who work with people who are using any drugs to look into that project. And I was hoping that you could use this as a plug to get more fentanyl test strips out into our communities, and to see what the process, how difficult is the process from a treatment provider agency or from a community provider agency.
To request the strips?
Yes.
Oh, I just put the form into the chat for everyone. So it's relatively painless. Just let us know how many units you want and then where to send it.
I have a question. Okay, fentanyl test strips are used in detecting fentanyl in street drugs, so they wouldn't be appropriate for use with us in a treatment center, right? I mean, it would just be opioid detection, or because we do that, we'd have a broad panel, or in MAT or any of our MAT programs. Because I mean, are we handing these fentanyl test strips out to individuals to use so that they can see if street drugs they buy?
Right, so that's why our distribution efforts have really targeted harm reduction organizations, needle exchange programs. So individuals that are actively using, organizations that engage in street outreach, law enforcement and first responders, because the hope is that individuals that are receiving treatment services are potentially using medication-assisted treatment and really not utilizing substances at that point. But you would be crushing up the pill if it's an opiate, or looking at the powder and then detecting the amount of fentanyl within. So really it's an effort to provide the fentanyl test strip coupled with the naloxone in distributing it to the client or the individual.
Because our people in treatment are using fentanyl. I mean, they're using fentanyl, they're using drugs that they know has fentanyl in it because they like the feeling. So it's interesting that, you know, I guess with street outreach, at least they know that those that don't know. So I get it. Okay, so thank you for the information.
Jolene, you've got your hand up.
Thank you, Jamie. Michelle, thanks for that information. I'm a little confused. Maybe I missed something. You mentioned the Southern Nevada Health District, but I don't think you said anything about Washoe County. Is that because Washoe County did not have a mechanism to do the fentanyl test strips, or is it just that
Southern Nevada Health, right? So Southern Nevada Health District has a grant to cover the purchase of fentanyl test strips. And so through their OD2A program, they're purchasing and distributing and educating with fentanyl testing strips throughout Clark County.
But nobody in
So,
Washoe County has that.
well, Washoe County is dependent on the state opioid response grant.
So somebody is doing it. The same thing. I'm confused why we're only talking about Southern Nevada Health District, but I mean, I
So there's
understand
two
I'm missing
mechanisms, right?
inclusive.
Sorry. There's two mechanisms
Okay.
for the distribution of fentanyl testing strips, the state opioid response grant and the Clark County Southern Nevada Health District. So if you're a provider within Clark County, you can receive your fentanyl testing strips through the Southern Nevada Health District. For anyone outside of Clark County, you can go to this link if you are asking for fentanyl testing strips, and we will send them to you.
Okay, so it doesn't have to be someone with SOAR funding. I understand now. Thank you very much.
Thank you, Michelle. To go back to naloxone, I apologize for beating this horse to death. One of the concerns we're having is like some of our first responders, some of our law enforcement, their naloxone is expiring. And we're having our school police officers are utilizing naloxone in a alarming rate. And again, all of this is anecdotal. I don't want to put anything on the record, but if we've got people who are using it all the time and they can't get access to more, that to me is a real problem. And down here we've robbed Peter to pay Paul, so we've got the people who need naloxone in their hand. But it's helpful to understand that your issue is basically like you only have so much money to pay for naloxone, and you're already at your limit for the month. So that's helpful for us to understand so that we can then.
It's also distribution channels. So there is like, with the vendor, the distributor who's distributing naloxone, there was a delay in getting it shipped as well. So we're trying to be as real time as possible to serve all the needs of the state, but we're limited to what they have to provide us to.
Absolutely, I completely understand. And hopefully there is some appetite at the state, because right now SOR funding is still technically grant funding, as is the funding that SNHD would have. Is there a plan to move some of the fentanyl test strips and naloxone into hard funding, for lack of a better word, as opposed to grant funding in the future?
I will have to defer to Shannon or Stephanie for that.
What do you mean by hard funding? Do you mean, I don't know what you just said.
In the government world, they call it hard funding when it's not fund dollars. So funds that aren't
soft money, right?
Yeah, so soft money versus hard money. So yeah, things that are not grants. So like the block grant would be soft money, but state general fund would be hard money. I apologize. That's my old government head coming back out to play.
But that is a question for long-term sustainability too, Jamie, and I appreciate it. So it is something that SOAR will potentially have to look at. And so that is a question that I can bring to our project director at the state.
Whatever happened to the liquor tax money? Did it just get subsumed and diluted? I mean, that was here in the state, we had specific money. When it was first enacted legislatively, it was supposed to go for detox. And then it was supposed to go for alcohol rehab. And then it was supposed to go for SUD. And now it's just poof. I don't know what it's used for. But, you know, we probably need to go back to some of this earmarked money and say, why is it no longer earmarked? Just what you said, Jamie. I mean, it's, if you want some hard money, even the earmarked money just kind of disappears.
This is Shannon, and the liquor tax money does primarily fund treatment. And we'd be happy to share a list of those subawardees out of that budget account if that's of interest in a future meeting.
Who said that?
This is Shannon.
Hi, Shannon. Okay, so yeah, it would be very interesting to see where Because we know anecdotally that during COVID, liquor use went up. So we should have made more money. And it's interesting it would be interesting to see. So how do we get that information from you, Shannon?
Yeah, I can prepare something for the next meeting and we can have a report out on it. I can also talk about the revenues that we're seeing in that budget account and how it's trending and how we're pulling those revenues in as well. So that's definitely something we can discuss.
Okay.
Wonderful. Thank you guys so much. Any other questions for Michelle and or Mark? Wonderful. All right. I know that this meeting is running a little bit long, but I'm hopeful that we're still able to hear Alyssa O'Hare present on the Multidisciplinary Prevention Advisory Committee priorities that were discussed.
Yes, I'm still here.
Wonderful. Thank you, Alyssa.
Is on to jump in. But thank you all for having me at this meeting. So I'm on the MPAC along with a few other people on this call. But through a technical assistance contract that I work on, we offered some TA to the MPAC to support their prioritization process. So just for the context, I'm sure all of you already know this, but the State Epidemiological Outcome Work Group publishes an EPI profile of behavioral health. It used to be annual, and recently they changed it to every other year. And the MPAC then uses that data to establish priorities for primary prevention of substance misuse that will be recommended to SAPTA. And so I volunteered to kind of help facilitate this process using the 2020 EPI report. I'm guessing that there will be another 2022 report published soon, and this is the nature of data. It always takes a little while. So just to give you an overview of the process that the MPAC ultimately used to prioritize their data, using the 2019 profile, the group had already narrowed down quite a bit what the priorities were. And then shortly after that, the 2020 profile was published. And so to use the work that was completed and not just say, oh, well, we have a new EPI profile, let's just discard all of that work. We used those more narrowed set of priorities as our starting point. There were about 20 or so. So it wasn't a particularly narrow or refined list. And so we used the 2020 data to narrow that down further to something that is manageable given the limited resources for primary prevention of substance misuse. So I used a toolkit that was developed under a previous SAMHSA contractor that is specifically for EPI work groups, and it recommends a number of different prioritization processes. So I got some initial feedback on which process might fit the best for Nevada's data and for the MPAC. And initially, we discussed using 3 specific criteria. Magnitude, so how big is the problem? Time trends, is it getting better or worse over time? And then comparison data to a similar state or to the country. It is noteworthy that no EPI profile in any state anywhere is ever perfect. And so also part of this process is looking at where there are data gaps so that we can have that continued improvement over time. And so we did identify some data gaps that we recommended to the EPI work group to see if it is possible for them to address those or not. It might not be possible in some instances. So in looking at this proposed process, the MPAC had a really great discussion about exactly what data indicators we were proposing to look at, and if these were in fact the 3 criteria we wanted to use. The decision was made at that point by the MPAC to add a 4th criteria, and that is severity of substances, and also to include a little bit of fiscal data to look at what are we already spending money on in terms of the primary prevention of substance misuse, to say, is there something we want to continue really honing in on, or do we want to also consider other areas that are not funded to the same degree at this point? So once that process was agreed upon, I took that process and extracted data from the EPI profile and reorganized it so that we can make, for the most part, sort of quantitative comparisons across the criteria that we selected. But in doing so, it became really clear that there was not sufficient severity data to really use that effectively. And so that was one of the recommendations back to the EPI work group to consider including more severity data where that is available. We just didn't have enough to actually compare, say, opioids to marijuana to alcohol in a truly meaningful way. So we did consider that more qualitatively when we looked at the data. I'm going to pause. Are there questions so far, or do you want me to tell you what the actual priorities were that we came up with based on that process? Okay, no questions. So or Linda, if you want to step in and clarify anything that I've said. We also did not have sufficient data to really look for health disparities. I do want to make that point. So what we had was basically age-related demographic data using middle school, high school, and adults as sort of the proxy for different age groups. So we came up with 2 recommendations for middle school students, and that is the current use of marijuana or cannabis. So the goal would be to reduce 30-day use as measured by the YRBS of cannabis or marijuana. Also, the current use of vaping or electronic nicotine delivery system devices. So those are the 2 middle school related priorities that the impact is recommending. For high school, it was current use of alcohol and current use of vaping and electronic nicotine delivery system devices again. Also using the 30-day YRBS indicator for those. For adults, the general adult population, we had 1 recommendation, and that was to focus on reducing current use of marijuana or cannabis. And we did have enough LGBTQ adult population data to examine, and there were 2 priorities that came up within that group specifically. And that was also the current use of marijuana or cannabis and the current use of cigarettes or tobacco. And I do also want to put a big asterisk on this, that we know these data are already old, and we want to be responsive to emerging issues that may not have been reflected in the 2022 or the 2020 EPI profile. And so, you know, it's really important to note that we are continuing to monitor new and emerging trends, and we'll continue looking, especially when the 2022 data are released, at, you know, does that change anything? So that is what the MPAC recommended. And I don't know, Linda, if you want to add anything, or Jamie, if you want to add anything to that. Linda says she has nothing to add.
Wonderful, thank you. I think this is great information and great data. And one thing I did notice on the agenda, the MPAC priorities are actually supposed to be presented and approved by the SAPT Advisory Board, but right now we have it as an informational item only, so we'll need to add this back onto the agenda for approval. So if everyone can remember this conversation for 2 months from now and we have to vote on it, I would appreciate it.
Can I just say, Jamie, there is a document summarizing this entire process with the final priorities listed. And I know it is posted somewhere, but I don't know where. Ben Trevino made sure to post it publicly. So, you know, I don't know if that could be distributed to this group, or if someone can point out where members of this board can access that it is publicly available. So thank you.
Yes, we will make sure to get that out. Stacy, I think I can find that for you. So if you can just send it out to the board members after this meeting, I would appreciate it. Wonderful. Well, thank you so much, Alyssa, for coming and presenting this great information. And then we will go ahead and close agenda item number 7 and open agenda item number 8, recommended items for the next meeting. And Esther, I think we can safely say that conversation around certifications of behavioral health professionals should be added to the list.
It should. The upcoming legislative session this is where we can make some major inroads. And so I think you should put that on an agenda item. Each of us needs to go to our legislative representatives for our needs as a field. So maybe we can discuss our unified need as a field, but certainly the, I think the certification or licensure is one thing. I think that Michelle Berry, we're going to work cooperatively with CASAT because we're trying to overcome barriers to get things done. So anyway, if you could put that on, it'd be, well, it would be at the behest of this group.
Any other requests from board members on agenda items for the next meeting? Close agenda item number 8 and open agenda item number 9. This is the second and final call for public comment. Again, no action may be taken on an item in this area. Elise.
Kendall was first. Can she go? And then I'll go after.
Absolutely. Sorry. Thank you.
Thanks, Louise. Yeah, I just wanted to provide something briefly in the public comment on behalf of Dawn Yohi. She had to pop out to another meeting, but as Elise had mentioned earlier and was briefly talked about, the Advisory Committee for Resilient Nevada, there is a meeting being held next Wednesday, April 20th at 9 a.m. During that meeting, the group is going over the drafted needs assessment for Senate Bill 390 and will be accepting all public comment at that time in order to put into the finalized version of the needs assessment. The agenda has been posted as well as the draft need assessment and a couple of other meeting material online. I know Dawn had shared the link in the chat. I can share it again just so it's more at the top of the group's list.
Thank you, Kendall. Appreciate it. Now, Elise, it's your turn.
Awesome. Thank you. So I just have an announcement for our folks up in the north. So the OD2A program has partnered with the UNR recovery community, NRAP, to hold a screening of Road to Recovery tonight. This is a anti-stigma documentary that the OD2A grant supported this year. So we'll be doing a screening of the 20-minute documentary and then a panel discussion. So if you are in Reno and looking for something inspiring and great to do, I would encourage you to come by campus tonight at 5:30. We have parking codes. I know that parking can be a challenge on campus, so we want to help facilitate people coming, so we can send you a parking code. I'll throw my email in the chat again if you have any questions, but tonight, 5:30, the Joe Crowley Student Union. Thanks.
Can you send that out?
Sure.
Can you, no, I mean, we can't come. We're out here 300 miles from you and we're busy doing stuff. Could you send that presentation to us?
I will. Yeah, it's a 20-minute documentary, and it chronicles the life of 3 people living in recovery. It talks about their story and how they experienced addiction and moved through that. It's just really great. So I will send that to the SAPTA staff, maybe to go out through the SAPTA listserv.
Right, because then we can send it out throughout our whole system.
Yep, I can do that. Thanks, Esther.
Thank you.
Thank you. Any other public comment? Wonderful. We will go ahead and close and 4 a.m. Thank you all so much, and we'll see you all in approximately 2 months. Have a great day. Thanks, everyone.
Good job, Jamie.
Thank you, David. Big shoes to fill.
Thank you all. Bye.
Stacy, do you have just a second? I want to make sure we get everything that needs to, while it's all fresh in our minds, to go over agenda items for next time.
Sure.
Awesome. Thank you. All right, I'm gonna see if I can share my screen. I don't know if that's gonna be possible, but that way we can look at it together.
Okay.
All right, are you seeing the agenda in Word doc form?
Yes, I am.
Awesome. Okay, so this will all be the same. We can take this off. Highlight. Okay, so that's done. Recovery housing, that's done. All of the, I mean, we'll change what the folks are talking about, but we definitely
Sure.
want the SAT to do an SOR comprehensive update, and I'll send this to you.
Sure, sure. Yeah, that makes it easier because me trying to sort through what everyone means to put on the agenda doesn't always work in my brain.
Right, right. Just delete these. We'll do it this way. And then, okay, so these are going to be covered. What did we want Shannon to talk about? Oh,
Let's see.
funding, where the liquor tax money is.
Yep, that was the last thing she was covering, yes.
Okay, is there anything else that we wanted Shannon to talk about?
I don't think so.
Okay. All right, and then Resilience Project, Kendall, was there anything we wanted that she was asked to provide? I know she was supposed to talk about the ACRN.
And she did talk about the acorn.
Yeah.
I don't think anyone had any questions or any carryover at the end of her conversation.
Okay, wonderful. Tracy, she talked about this. Was there anything that else we were wanting to follow up about Sinar?
Let's see. The only thing I can think of with Tracy was I know she was going to be receiving the list of the funded people.
Got it.
But as far as Sinar, you know, I've never really understood Sinar. I know it has something to do with tobacco, but when I re-listen to the recording, if I catch anything, I can run it by you.
Okay, perfect. I think that that's covered. Oh, you know what? I would just be curious to keep it as a standing item of, did SAMHSA approve the plan?
Okay.
And help if I spelled SAMHSA right. Elise is gonna add data on who is rejecting the, I don't know, open beds requests.
Yeah, that's what I was going to say. Requests. Sounds about right.
Okay, and then so CASAT, it's only the SOAR comprehensive update. That's the only thing that we asked is like follow-up.
Over as a possible action.
Make that red so we don't forget, and then that'll stay the same and that'll stay the same. We may have one or two more things to add, but I think this is what we need to talk about.
Okay, that sounds good.
You know what, we wanted to, the behavioral health certifications, we'll need to add that in somewhere. I'm just gonna make it behavioral health certifications. Why is it so hard? I think that might be a goddess thing. I don't know. That might be a conversation.
Because who's making it hard? Is it the state or?
It's, so again, I'm not a treatment provider. This is not my bailiwick. I've just listened to people talk about it for ages and ages. My understanding is the process, so every behavioral health certification, whether you're a social worker or sorry, let me reject that.
Or a facility, yeah, anyone that needs certification.
Yep, every certification is different, and some boards, like the LCSW board, may be easier to work with, and again, I'm making all of this up, maybe easier to work with than the Marriage and Family Therapist Board, and MFTs may have a terrible system and it may take forever. I know that under Sandoval, this was something that he really pushed in his last couple of years in office, and some significant changes were made. I know Agata, I don't even remember Agata's last name. She's just Agata. She works at the state and she kind of oversees all of the boards.
Oh, so that would be, she would have good input.
Yeah, I was gonna say maybe Agata. And then let's ask Shannon. You know what? I lied. Let's not even ask Shannon. Let's go directly to Dr. Woodard. Not that Shannon's not great, but I don't think Shannon's got enough institutional knowledge, and I think Dr. Woodard would have better insight.
No, and I agree with that.
And then, so I know you wanted to, you know, have all of us talk to our respective legislators. And I think that's a great idea. I'm just not sure how we put that as an agenda item.
Could we just do like an update for maybe, let's see, so if someone were able to reach their, because it's not everyone has the same legislator, I'm assuming.
Right, correct.
So some people may not get a response for a while and some may get an immediate response. So maybe next meeting, I wonder if we can just incorporate that to people's updates.
Okay.
Like,
so maybe as a standing
how would,
informational update.
Yeah.
Okay.
And I'm not sure who Esther wants people to, I mean, which people does Esther want to reach out? Is it the board members or is it everybody?
Yeah, I don't know.
Okay.
I know, I mean, so an interesting.
So we could probably do it as an agenda item where you can throw in, has anyone heard from their legislative council regarding this? And then we can open it up as a conversational piece or informational item, or you would probably have a better idea. You sit on a lot more meetings than I do, so you probably.
That I do. So I'm actually thinking these, so every region has their own behavioral health board. And each behavioral health board gets a bill. And so I know, and everybody's looking, because I sit on the Clark one, everybody's looking for the item. Everybody's looking to try and figure out what they want their bill to be.
Right.
So maybe that is just something that we mention is if you're interested, each behavioral health board gets their own bill. Each mental health consortium gets their own bill, or like there's children's mental health consortiums. And I don't know how many of them there are, but there is at least 2 or 3, and they either get one bill between the 3 of them or a bill. I can find out the details on that, because that's, I don't sit on those boards, but I sit on boards with people who run those boards.
Yeah, and I sit on a lot. Backed off, but now that she's left, I'm back on Jessica Floods and Valerie. I call her Cow Happy, but I know it's
I know
Cow Hate.
I know Valerie. Yes. Okay, wonderful. So those are our notes. I'll go ahead and share this with you right now.
Yep, and then I'll add it to my stuff. So when I start typing it up, I'll make sure I have all that.
Okay, perfect. I will send this off to you right now, and I think we're great. Great job. Thank you so much for everything. We were able to keep quorum 30 minutes after we were finished. I feel like
we did. Yeah, I counted at least 8, so I knew we were doing okay.
Okay. Fabulous, fabulous. All right. Well, Stacy, thank you so much, and we'll see you soon.
Okay, talk to you later.
All right, bye.